Our next speakers will be Dr. David Mott of the UW School of Pharmacy and Barb Michaels with the Aging and Disability Resource Center of Brown County. They will discuss their community academic partnership, looking at how community pharmacists can help older adults modify their use of drugs that can increase the risk of falls. Thanks to both of you, and go ahead.
Thanks, Sam. The situation in Brown County, which is the reason that I'm here, is because I work in the community in Green Bay, serving Brown County, and I work with older adults every day at the Aging and Disability Resource Center. So I'm touched by those folks on a daily basis and hear and live their concerns with them. As you can see from this slide, falls are increasing in our county, and they're costly. It is our number one injury in Brown County, as reported by our emergency departments, and we have 4 ERs in Brown County. Another slice of the data is other organizations that are also monitoring falls, one of which is our largest EMS provider, which is Green Bay Metro Fire Department, which is one of 18 fire departments that serve the county. So for example, for that fire department in 2013, they were going on 4 fall calls per day. And now in 2017, looking at a 5-month average so far, that's also increased to 5 per day. Another slice of the data is from the Wisconsin Hospital Association data in terms of the numbers being seen in the emergency departments at our 4 ERs in Green Bay. So back in 2013, that number averaged to 21 per day that was seen in the ERs, and now that is also increased on an average to 23 per day. At the bottom, you can see the costs, $14.8 million in 2013, and now an increase to 18.8, which is about another $4 million hike in a few years. Looking at another slice of the data on ER costs, this was another slice of 4-year data that shows a 64% increase in ER fall charges in our community of Brown County. So the role of the ADRC in our county, we have been involved for quite some time, a long time actually, in falls prevention in one way or another, motivated by the problem and the costs, which also bring medical providers and community organizations to the table to work on solutions and figure out what may work. But personally, working with older adults at the ADRC day in and day out, I'm also motivated by the concerns expressed from older adults directly to us. And when we offer classes, which as Jane talked about stepping on, we offer other classes on fall prevention that our medical providers offer. The classes fill, and we have wait lists, and people are concerned about it, and they're talking about it. And word of mouth spreads in a good way, which tells us it's not just a problem on paper. Older adults are concerned about it. So our coalition actually has been working on this for quite some time, actually since 2005. And the coalition has evolved over time, and it's involved the list of organizations that you can see on the slide. From our 4 Green Bay hospitals to our higher education, we're fortunate to have Bellin College, UW-GB, our technical college that also supports this effort in many different capacities. Our fire department, public health, a community pharmacy, our Northeast Wisconsin Regional Trauma Advisory Council is also very involved in it because they realize it's the number one injury. The council is made up of medical providers from the ER as well as the EMS, both police and fire. So it is a topic that's always addressed at these council meetings. The other up here is UW School of Pharmacy, which Dave Mott will talk about shortly. And then Metastar is involved with us here in Madison. Their quality improvement organization have also supported our coalition with data. And then, of course, our ADRC. The current coalition steering committee at this time, this is a visual of the logos of who is involved in terms of the decisions made on the goals that we focus around falls prevention. So it's our 4 hospitals, Bellin Health, Aurora, St. Vincent's, and St. Mary's, our ADRC, and Public Health. approaches to falls prevention that we've taken over the last quite a few years since the coalition started falls in a couple of broad areas. Consumer education. We have done and still do the stepping on classes because the evidence that Jane shares, we also visually see the evidence of how that can improve falls risk for older adults. So we are motivated to continue that program as well as other classes that we offer. The hospitals and ADRC have prepared a common brochure that we all distribute to our customers and to their patients that provides how-to information on preventing falls. We do offer screenings to help just, again, with the general awareness of what folks can do to prevent falls, which is from balance screenings in the community to in-home screenings that are more one-on-one with an individual in the home to create an action plan of what they can do to prevent a fall. And then a variety of media publications, which one that I highlight here is we're fortunate to have an experienced faller, is what I tag him with, the line, who's a great writer and has had falls and really wants to share his experience and knowledge with his peers, his older adult friends, to help prevent them from experiencing some of the same things that he has done as a result of a fall. We've also offered provider education in collaboration with our partners, hosting continuing education for medical providers. Most recently, in the last year, we've started to also focus on the faller and preventing a repeat fall. The stats are out there that if you fall once, you're very likely to fall again. So with our ER departments and our EMS staff, we've worked some processes and tools and put those in place to connect those fallers on site at the ER or at the home when an EMS person is picking that individual up just to get them back on a chair and then leaves, to connect them to community resources to help them prevent the fall from occurring again. And then lastly, which is really what we're working on right now to add to the mix, is to try to get greater community engagement of other professionals in the community that can help support our work and expand our reach. So very quickly, the history of doing Stepping On, we started in 2006 with the program and have continued on with it because of the results that we see. We've reached 1,700 participants or older adults since we started the program, which in some way you may say, well, that seems like a lot, but we have 43,000 older adults in Brown County that are 60 plus, so we're barely scratching the surface. It was that program and the class of the 7 classes where the pharmacists spoke that really presented to us a huge concern about medications and what that contributes to falls. Our folks asked over and over again, can we get more time with the pharmacist? Can you bring him back or her back? Can we get more one-on-one time with them to understand what their medications were contributing to their fall risk? So it was that we wanted to address that concern because we listened and started a small group of community folks that partnered together to see what we could do in a different way, utilizing pharmacists to address that concern. And that led us to Dave Mott at the UW School of Pharmacy.
Thank you, Barb. As Barb mentioned, medications are a concern for older adults. They want more information about medications, and they want the opportunity to meet one-on-one with a pharmacist to learn more and to reduce falling risks. Several medications are considered to be falls risk-increasing drugs, or FRIDs, because their use has been associated with falling. Several therapeutic categories of medications are considered FRIDs. Such medications as sedative hypnotics used for sleep, antidepressants, benzodiazepines used for anxiety, antihistamines used for allergies, anticholinergics, such as medication used to control bladder function, antipsychotic medications, muscle relaxants, and medications used to control blood pressure. There are two main effects that link FRIDs to falling. First, because FRIDs act in the brain, they can cause mental confusion, sedation, impaired coordination, and/or blurred vision. Second, some FRIDs dilate blood vessels, causing orthostasis, or the dizziness that results when you stand up too fast from a seated position. Each of these effects, alone or in combination, can contribute to an older adult falling. Unfortunately, use of FRIDs is common. A recent study my team conducted showed that nationally in 2012, over 85% of community-dwelling older adults used a FRID, and over 40% used 4 or more FRIDs. The key to improving medication safety for older adults is to have their medications reviewed regularly to assess how each medication is affecting them, to make any needed modifications, and to continue to monitor the medication effects. For several FRIDs, there are safer alternatives that can be used, or there are safer dosages that can be used that can reduce the risk of falling. Fortunately, the CDC recommends older adults at risk for falling have their medications reviewed and then modified or monitored to improve safety and reduce the risk of falling. So medication therapy management, or MTM, is a new role for pharmacists that can be utilized to review and modify medication use for older adults. Now, MTM is not the typical consultation received from a pharmacist at a pharmacy when a patient obtains a prescription. Rather, think of MTM as a medication checkup, similar to a dental checkup or a checkup at a physician's office. The goals of MTM are to ensure the use of appropriate medications, the proper use of medications, and to detect and prevent bad effects from medications. As the picture implies, during a medication checkup, a patient meets with a pharmacist, typically by appointment, and together they review the medications a patient is taking to determine appropriateness and effects. Any suggested modifications are discussed with the patient and the medication prescriber. And fortunately, the School of Pharmacy here at UW has been training pharmacy students to provide MTM for about 10 years. So with FRIDs and MTM as a backdrop, the two main questions that the partnership between Barb, myself, and others in Brown County addressed were, first, can we work together to develop an MTM program focused on FRIDs? Together we developed an algorithm and training program for the pharmacist to review FRIDs. We used evidence-based medicine to develop a list of suggested alternatives for modifications, and we developed ways for the pharmacist to communicate with patients and providers. The second question was, will the FRID-focused MTM improve medication safety for older adults? We needed to make sure that older adults would meet with the pharmacist and that the pharmacist would be effective in reviewing, assessing, and modifying FRID use to improve medication safety. These two questions were what our team focused on. Our team is listed here on the slide, and we were fortunate to receive some grant funding to help us along our way. So this is a quick overview of our study. Basically, we worked with two groups of older adults who completed the Stepping On program to test the impact of the FRID MTM program. One group, the treatment group, met with a pharmacist for up to 60 minutes to receive the MTM program, and the other group did not meet with the pharmacist. We followed each older adult for 6 months after the MTM program, looking at the medications they were taking. We expected to see more modifications of FRID use among older adults who met with the pharmacist. And here's a slide of the effects of the MTM program on stopping all FRID use. Almost 80% of FRID users stopped using all FRIDs 6 months after receiving the MTM program, compared to just over 25% of control group older adults. The differential impact is pretty remarkable. In summary, the study showed that our community academic partnership could develop a community pharmacist-provided, FRID-focused MTM program, and that the MTM program was effective in improving the safety of medication use and reducing the risk of falling among older adults. Additionally, older adults were very satisfied with the interaction with the pharmacist and found it very useful.
Just a couple of things from our perspective, living in the community and working with older adults. As I mentioned, the numbers that we have been able to touch with some of our fall prevention classes, and that it seems like a lot, yet our population of older adults is very large, with about 43,000 older adults, 60 and older in our county, which is about 14% of our population, and that's expected to grow. You saw some of the earlier slides that Jane had as well. It's expected to increase to 24% in a few years going forward. So there's a lot of awareness that needs to happen to educate folks on what they can do to prevent falls, and many things are very simple, but we need to get that awareness out there, as well as support for resources to help move that education forward. And then also we really see, having been a part of the concern regarding meds and fall risk and being a part of the research study and hearing that impact on those older adults, we really see the need for greater access to pharmacists for that annual med checkup.
Other implications center on adoption and sustainability of such services. The first deals with adequate payment to pharmacists for the MTM service. Some payment programs exist that do pay pharmacists for broadly defined MTM services, but it would be good to pay for a falls-specific MTM service. Further, Wisconsin statutes and regulations recognize pharmacists as healthcare providers and allow prescribers to delegate patient care tasks to pharmacists. It would be good to have policies that allow payment to pharmacists for these delegated tasks. This essentially is a referral process whereby physicians, other prescribers can refer older adults to pharmacists in the community for such services. We have a referral system for other allied health professionals, such as physical therapists. We should work to include pharmacists in that system to facilitate patient access to care and provide payment for the referred services. Second, for community pharmacists to be an effective member of the healthcare team, they need to have access to electronic medical records with bidirectional communication. Pharmacist EMR access will facilitate review of patients' medical and medication history, as well as facilitate communication between pharmacists and other providers. In our study, pharmacists communicated recommendations to prescribers via phone or fax. This communication approach is inconsistent with the workflow of today's medical providers and impedes improving medication safety. And then third, thinking about expanding such a service to rural areas of Wisconsin. Again, Jane's slide at the beginning of showing what's going to happen with the demographics in rural areas. Policies should explore the feasibility and effectiveness of utilizing telehealth technology for pharmacist-provided MTM services, as these are important due to access constraints and fragmentation of care in rural areas. In-home or in-clinic access to a trained pharmacist via video or telephone could be a very effective means to deliver similar MTM services. Thank you.
Open up to any questions either in the audience or elsewhere. We'll have a microphone available. Let's start off then. Dr. Mott, what are the prospects for next steps for this study, either in Brown County or elsewhere?
Yeah, so we expanded a similar study into 4 other counties in the state. After we finished with our Brown County project, we went to Outagamie County, Calumet County, La Crosse County, and then also in Brown County for the second phase. And we were involved in seeing if we could spread to more ADRC partners, more communities, and then more community pharmacies. We were successful in implementing that program in the other pharmacies. We had similar success in terms of pharmacists modifying FRID use. Now it's just trying to connect with other community partners, other community pharmacists, also have ideas of connecting with health systems in the state. Barb showed the slide of the partners in Green Bay, and I know Barb has had conversations with the health systems up there to try to talk about implementing this medication review algorithm, either for emergency department discharge or hospital discharge, or just try to expand it into ambulatory and other community pharmacies.
Dr. Mott, could you repeat one statistic that you had shared? You talked about the fall risk increasing drug and the percentage of the adults that use 4 or more.
Yeah. The study that we did, data from 2012, 40% of community dwelling older adults used 4 or more of those FRID medications.
So also for Dr. Mott, 76% that stop using the FRIDs, since they are obviously depressed patients or high blood pressure patients or a combination of such conditions, what happened? Were they switch on less risky for fall medication, or what happened to them?
Yeah, so a lot of the medications that were removed or modified actually were, a lot of them were over-the-counter medications used for allergies or sleep. Medications, acetaminophen for pain with diphenhydramine, which is basically Benadryl. A lot of older adults were using those medications, so the pharmacist suggested alternatives for sleeping instead of those. In situations where you had medications like antidepressants or blood pressure medication, the focus was really on, number one, finding a safer alternative, right? There are safer antidepressants, switching patients to the safer antidepressants, and then monitoring follow-up to make sure things are okay. And then blood pressure medication, it's really about looking at the dose of that blood pressure medication, seeing if the dose can be reduced, and then monitoring for effects, especially the orthostasis, the dizziness upon standing. So you bring up a really good point, and we're not just talking about completely stopping going cold turkey. We're talking about modifying and monitoring. That's a really important piece to this.
Thank you very much for your testimony. Doctor, what's the current state of research regarding the interaction of drugs? I know anecdotally, not a professional, but I hear many people say I'm on X amount of different drugs. And I say, do you have any idea what the interaction is? And maybe some of the students can even speak to that. But is there a lot of research being done of how these things interact, what the side effects are? Which ones are, and then often they, as you say, they go off of them and they feel much, much better because of the cocktail that they're taking. So is there any research done? And maybe you can just speak to that a little bit, if you will.
Yeah, there's a huge focus on drug interactions, use of multiple medications at the same time, and the impacts on not just older adults, but all patient populations. As I'm sure our students can talk about, I know in the pharmacy school, we spend a lot of time with our pharmacy students talking about drug effects, drug interactions, how to intervene with patients, how to communicate with patients, how to identify alternative medications, how to communicate those modifications to prescribers. So it's definitely something that is at the top of the list in terms of things that pharmacists pay attention to, and other healthcare providers as well.